And so for the second panel, we're asking similar questions and also some newer questions in the space of advanced lung cancer. And we're joined by 3 new panelists. And so we have here Dr. Marmarelis, Dr. Sacher, and Dr. Hegde. And similar to what Jack just did, I'll have each of them introduce themselves. And before you introduce yourselves, I wanted to make sure it's okay. In this setting, we've been referring to everyone by their first names. Is that fine with all of you? Perfect. And so Melina, let's start with you in terms of introducing yourself.
Great. Hi, everyone. Thanks for having me today. I'm Melina Marmarelis. I'm a medical thoracic oncologist at the University of Pennsylvania with a specific focus in lung cancer and mesothelioma.
And let's Adrian.
Thanks, Ibiayi. I'm Adrian Sacher. I'm a thoracic oncologist and affiliate scientist at the Princess Margaret Cancer Centre in Toronto, Canada.
Perfect. And then we'll round it out with Aparna.
Thank you. I'm Aparna Hegde. I'm a thoracic oncologist at UAB, and my interest is in drug development.
Perfect. So over the next 55 minutes or so, we'll think through some, I think, exciting questions that really get to the core of how we think about newly diagnosed metastatic or advanced non-small cell lung cancer and some of the nuances in practice. As you heard from the previous kind of panel discussion, management of early stage lung cancer is very nuanced and is borrowing on a lot of the principles that we use in advanced lung cancer. And so let's start first. So kind of a common scenario that we all encounter in clinical practice. You have a newly diagnosed patient who has a new diagnosis of metastatic non-small cell lung cancer. And we know now kind of from multiple kind of practice changing publications and kind of with the shift in the therapeutic paradigm that biomarkers are very critical, right? We always strive to get it right in our first line therapy. And because our audience kind of encompasses kind of different expertise, I wanted to first make sure we're all on the same page by discussing what are the key biomarkers for newly diagnosed metastatic non-small cell lung cancer. What do you consider the must test? And we'll have anyone, perhaps so everyone doesn't talk at once. How about Adrian? Let's have you start off.
Absolutely. So I think in the metastatic setting, we're really in a reality where you have to have NGS on everyone, and then also PD-L1. There are kind of a list of potentially targetable genomic drivers is expanding rapidly. I think most recently with kind of KRAS G12C entering, and I think too beyond just our standard of care options, we increasingly have clinical trial options in the metastatic setting that are looking for very specific genomic targets. And so having broad NGS not only ensures we can kind of give people all standard options, but that we can identify trials for them as well.
And when you say broad NGS testing, and this is, I just want to clarify, this is to distinguish from doing single gene assays like FISH for ALK or kind of even looking at PCR tests for EGFR. And in a practical sense, can we kind of, I know that that's still employed by centers and there is some diversity in practice, to kind of talk about why that type of strategy may not serve us as well as comprehensively looking for all of these things at once. And maybe we can have Melina start and then Aparna add anything additional you might have.
Sure. So I think the first thing I'll say is that the NCCN has a list of biomarkers that they recommend that are tested prior to starting first-line therapy, and that continues to expand, with every iteration of the guidelines. So including EGFR, ALK, ROS1, RET, BRAF, MET, and it keeps growing. And so, it may have been feasible in the past to do single gene testing for a few of these. But really, it's been shown now that it's both more time efficient and cost effective to actually do a larger next generation sequencing panel right at the outset, so that you're not wasting the patient's time, you're not wasting hospital resources or precious tissue, from a biopsy. So I think that's certainly the preferred approach. There's also guidelines to incorporate concurrent liquid biopsy testing, so meaning from peripheral blood, to also kind of get to the answer faster. So this is an evolving space, but I think the guidelines are clear that it really needs to be a broad panel.
Yeah, so I agree with whatever has been said so far. So our practice over here is also to get a comprehensive panel upfront, regardless of histology, because for adenocarcinoma, I think it's absolutely necessary to pick the first line of therapy. But in squamous cell carcinoma, having this comprehensive panel helps us plan for clinical trials down the road. So we are not kind of scrambling when the patient has disease progression. And also now there is a KRAS G12C inhibitor that's FDA approved in the second subsequent line setting. So it would be good to have that information upfront, so we get a comprehensive panel here. And yeah, with sequential testing, we end up losing tissue, wasting tissue, and it also takes longer. So that I agree, there is data now regarding potential cost savings, as well as shorter or at least equal turnaround time with a comprehensive panel. So that's our practice. And we over here also do ctDNA and tissue NGS at the same time. So this also helps us save time. Sometimes, we find out after 2 weeks that the tissue isn't enough. So, kind of do both at the same time instead of waiting.
So a lot to unpack there. So I think that one of the advantages of having a virtual forum and having forums like this is that we get oncologists who are practicing in multiple locations. And so I get to kind of get us an appreciation of whether there's variation in practice. And so Aparna just said that internally they do, at least at our institution, they would do concurrent liquid and tissue testing. And can you clarify, do you have an in-house tissue testing platform, or do you send out?
We send it out.
Okay.
Yeah.
And then is there any difference? Do you kind of, Adrian and Melina, also do both at the same time? And do you use a send out or an internal panel?
So we have an internal tissue panel, so from a biopsy, and then we send out for liquid biopsy for peripheral blood. That we have an initiative to move that to kind of the very first visit, or even soon, or even before that. So it is kind of part of our pathways and guidelines to incorporate that right up front.
For us, we do our kind of a broad NGS and RNA-seq panel internally, but part of that is just because we're also kind of the hub for all of our local cancer centers for testing as well. So we do it in-house, and then we bring in even more. And then same for ctDNA. We like to do both in tandem as well. And I might actually add on there, like, what are all the centers here doing in terms of reflex testing? So for us, the pathologists order the NGS panel way before we even see the patient. Is that kind of standard for everyone else as well?
We have specific guidelines about reflex testing, and a sample has to meet those in order to be reflexed. And it, some of the parameters are that it's non-squamous. It has to either be a certain size or be a lymph node or a metastatic biopsy. So there is a kind of a workflow, but the majority, when we look at it, do get reflexed now. That should.
So for us, we have a weekly tumor board meeting where we discuss all of our new patients who are coming to see us the following week. And we kind of, look at the stage and the histology, and we initiate the genomic testing as well as PDL1. Because in earlier stages, we use our in-house panel because I don't think we need a huge comprehensive panel in earlier stages, because the FDA approvals are only for limited things, just EGFR and maybe PDL1 because of the recent atezo approval. So we look at the stage. The pathologist probably doesn't know the stage when they have the biopsy. So we wait for the weekly meeting to decide who to send out the tests on.